RSI is to prevent aspiration or minimize the chance of aspiration. But drug assisted intubation has other objectives also. You want to give the best sedation and paralysis so that your chances of intubation is much higher. You don't want a moving patient when you do a laryngoscopy. Number 2, RSI provides, the aim of RSI is to increase the safe apnea time during your airway manipulation. Objective of RSI is to maintain organ perfusion. You don't want the patient to buck and increase the intracranial tension. You don't want to produce a secondary brain injury during your laryngoscopic attempts. That's why you do a rapid sequence intubation. But we have moved away from the original SILIX to now what is called as modified rapid sequence intubation. The few important differences are we no longer insist on Ryle's tube. We no longer insist on head down position for intubation. We are okay if it is supine or ramped up position is also okay. Even a head up position is okay if the clinical situation allows. We have moved away from inducing with barbiturate to other newer induction agents like propofol, ketamine, etomidate, etc. Rocuronium is acceptable as a relaxant of choice if you have sugammadex and if suxamethonium is contraindicated. And you are no longer dogmatic about cricoid pressure. If you have problems in ventilating a patient or you have problem in visualizing the vocal cord, you don't have to be dogmatic in